Good morning. Today we will have a lecture on the etiology of malocclusion, local factors. Last week we discussed the general factors and today we will be dealing with the local factors. And as for the learning outcome, at the end of the lecture you should be able to classify the various etiological factors and also describe the etiological factors causing different types of malocclusions. So there are 11 local factors causing various malocclusions. They are anomalies of the number of teeth, anomalies of tooth size, anomalies of tooth shape, abnormal frenum attachments, premature loss of teeth, prolonged retention of deciduous teeth, delayed eruption of permanent teeth, abnormal eruptive path, ankylosis, dental caries, and improper dental restorations. So we will be going into the details of each of these factors. Anomalies of tooth number. So in order to achieve a good occlusion, there has to be a normal number of teeth present, and if there is presence of extra teeth or an absence of one or more teeth, such situations lead to malocclusion. As we've already understood in the previous lecture, heredity does play an important role in such anomalies of number of teeth, and also there is a relatively high frequency of the presence of either extra or missing teeth associated with congenital anomalies or deformities such as cleft lip and cleft palate, and also the presence of generalized pathosis such as ectodermal dysplasia, cleidocranial dysostosis, and many other deformity states do affect the number of teeth in either of the dental arches. First anomaly we will be discussing is the supernumerary teeth. These are extra to the normal complement and have abnormal morphology and do not resemble normal teeth. So that's how supernumerary teeth are termed. And the most common supernumerary teeth you can find are mesiodents, which are present between the two central incisors. And if you find extra teeth that resemble normal teeth, they are known as supplemental teeth and they are not termed supernumerary teeth. So what are the clinical implications of supernumerary teeth? It can lead to non-eruption of adjacent teeth. Also, they can delay the eruption of adjacent teeth or deflect the erupting teeth into abnormal locations, and also can cause crowding in the dental arches. Missing teeth. So according to Butler's field theory, if one or more teeth are missing, the absent tooth will be the most distal tooth of any given type. That is, if a molar is missing, then it's usually the third molars. If an incisor is missing, it's usually the lateral. And if a premolar is missing, then it's usually the second premolar. So congenitally missing teeth can cause spacing in the dental arches, apparent swallowing patterns, also lead to abnormal tilting or axial inclination or changes in the position of the teeth, and usually the absence of permanent teeth may result in over-retained deciduous teeth. So treatment objectives would be to either create space for prosthesis or close the spaces, depending on the individual treatment objective of each patient or individual. Also, it depends on any other concurrent malocclusion states the patient might be suffering from. However, it's limited to certain areas or certain regions in the mouth, and your treatment plan should include a comprehensive plan to include how you're going to manage this particular space or this particular missing tooth. So coming to anomalies of tooth size, there are two anomalies we will be learning about. One is microdontia and other one is macrodontia. Microdontia is the term used to describe teeth which are smaller than normal. There are three types: through generalized microdontia, relative generalized microdontia, and the microdontia involving a single tooth. Here, there is nothing much we will need to concern ourselves with the orthodontic treatment. Usually, if the patient is asymptomatic and the teeth are healthy and the periodontal structures are healthy, you can advise the patient to close these spaces, or else you can leave the patient uh, as it is without any treatment. However, if the patients are inclined for a comprehensive treatment, then you can work alongside your prosthodontist and discuss how to manage the spacing, maybe with or without the use of prosthesis. When it comes to macrodontia, this is the term used to describe teeth which are larger than normal. There are three types: true generalized macrodontia, relative generalized macrodontia, and macrodontia involving a single tooth. So usually macrodontia can lead to crowding of teeth. So it becomes evident that you are able to recognize these generalized or single tooth malformations and involve them in your treatment plan. If there's crowding, there are several ways of treating crowded teeth. So we'll be going into the details of how to deal with these in later lectures. However, if it's a single tooth, then again you need to work with your prosthodontist and endodontist to see how much of a reshaping or change of morphology of this particular tooth is advisable, and also it depends on the extent of or the size of the pulp. Based on these parameters, you can either reduce or change the tooth size and shape, or else you can uh, again treat it with or without a prosthesis. The third factor is anomalies of tooth shape. Anomalies of tooth size and shape are often interrelated. Abnormally shaped teeth do predispose to the development of malocclusion. So the first aspect is the presence of peg-shaped laterals, which is accompanied by spacing and also migration of teeth. So as with the spacing, the treatment plan and the clinical implications are the same with missing teeth or microdontia. And the next factor is abnormally large cingulum on maxillary incisors. So this prevents establishment of normal overjet and overbite, and also the involved tooth is usually in labial version due to the forces of occlusion. And the third factor is the additional lingual cusp of mandibular second premolars. So what happens here is there is increasing the mesiodistal dimension of tooth, and again this can be considered as macrodontia affecting a single tooth. And again, the treatment plan is straightforward. It will be the reduction of or elimination of crowding, or you have to determine if these if these teeth can undergo reshaping. The next anomaly is fusion or fused teeth. So fused teeth arise through the union of two normally separated tooth germs. Fusion may be either complete or incomplete, and some physical force or pressure produces contact with the developing teeth and their subsequent fusion. So that is how two germs get to fuse. So fusion may lead to spacing in the dental arches, and also this indirectly will affect aesthetics, and also can complicate its movement by orthodontic means, because it's as good as the moving two teeth, but these two are connected at the crown level, and then it becomes challenging to move these teeth in question. The next anomaly is gemination. This results from the attempt at division of a single tooth germ, leading to the formation of two incomplete teeth. And this can lead to crowding. It can also affect occlusion and definitely aesthetics. So when you come across such teeth, it's better to work alongside your prosthodontist and endodontist and come out with a comprehensive treatment plan for such teeth. And the next anomaly is dilaceration. It is characterized by an abnormal angulation between the crown and the root of the tooth, or angulations within the root. These usually occurs due to trauma during the period in which the tooth is forming, and certain areas are calcified and the tooth is changed and the remainder of the tooth is formed at that particular angle. So that's how the malformations of the root take place. So this poses a challenge when such roots are present in premolars or teeth which you usually extract as part of orthodontic treatment. At times you need to extract these teeth surgically and then go about with your routine orthodontic treatment. However, they don't directly affect orthodontic treatment, and they can be easily surgically removed, and your orthodontic treatment can continue as planned. The next anomaly will be the abnormal frenal attachments. So this is nothing but the fibrous tissue attachments such as the labral frenum between the maxillary central incisors. When they're placed in abnormal positions can cause spacing, and there is a test to determine if there is the role of frenum in such spacing, and that is known as blanch. So a blanch test is performed when you feel that the frenal attachment is extending beyond the central incisors. So you can tug on the upper lip, and if you see any blanching in the area of the frenal attachment between the maxillary central incisors, then you can confirm that the fibrous frenum is extending beyond. And in such cases, you can subject the patient to frenotomy or frenectomy, wherein either partial or the entire frenum is dissected. And this is usually performed using laser, and that's one of the preferred choices by both periodontists and oral surgeons. What is the clinical implication, or when exactly do you need to do this procedure? So, whenever you notice midline diastema and there's no other causes other than the frenal attachment causing midline diastema, and if that's the only space between the two central incisors and the rest of the dentition appears normal, then it becomes important to assess this frenal attachment. And if you confirm that this is the cause of midline diastema, it becomes important to eliminate this cause by performing a frenectomy or a frenotomy. So certain times there is two schools of thought, wherein the first school of thought says that a frenectomy can be performed before the start of treatment, and another school of thought says frenectomy can be performed after the space closure has been completed. However, both have their indications and contraindications, wherein if it is performed before, they state that the scar tissue might prevent healing or delay the movement of teeth and thereby closure of space. However, if you see a relatively small or less than 2 millimeters of diastema, then it's usually possible to bring the central incisors completely together before performing a frenectomy. The next factor is premature loss of deciduous teeth. This could be due to caries, trauma, endocrinal disturbances like hypothyroidism, and any metabolic disturbances like hypophosphatasia. So when a primary tooth is lost before the permanent successor has erupted, the bone atop the permanent tooth can reform, thereby delaying its eruption. Also, when the eruption is delayed, there is more time for the adjacent teeth to drift into the space, worsening the condition or causing malocclusion to occur. So if a primary tooth is lost before age 4, it is advised to subject the individual for a radiographic analysis and to check on the developing permanent incisors, and the space should be observed regularly so that any interceptive measures can be undertaken. And if when it comes to the primary cuspids, if there is a generalized lack of arch length in both maxillary and mandibular dental arches, so the deciduous canines are frequently shed prematurely. And in such cases, what happens is nature attempts to provide more space to align the permanent incisors that have already erupted. So this type of premature loss is often a clue for further guided extraction. That is, you will have to subject the patient uh, for serial extraction. So we will be going into more details on serial extraction. We did speak about it in the chapter on interceptive orthodontics. So you will be learning more on serial extraction in your lectures from pedodontics and also oral surgery. So I'm not going to touch serial extraction again. So what happens when there is loss of two deciduous molars? So this can cause mesial drift of the first permanent molars and blocking of the eruption of the second premolars. So when the premolar is attempting to erupt, it can be deflected either buccally or lingually into a position of malocclusion. So what happens when two or more primary molars are lost prematurely? In addition to drifting, there's also loss of posterior dental support, and the mandible may adapt its position, sort of compensatory mechanism with an adaptive occlusal function, and this will result in the development of a posterior crossbite. So also these positional crossbites have an effect on the TMJ, the musculature, and also the growth of the facial bones, and also will affect the final position of permanent teeth. So that's how the loss of loss of primary molars can have an adverse effect on permanent teeth and the overall health of the individual. So it becomes extremely important to try and save these teeth, and if not possible, provide space maintainers. So we will be going into more details on space management in subsequent lectures. Now, prolonged retention of deciduous teeth. So this is another factor which can lead to the development of malocclusion. So this refers to a condition where there is undue retention of deciduous teeth beyond the usual eruption age of their permanent successors. So a deciduous tooth that fails to undergo resorption will prevent the normal eruption of its permanent successors. So it becomes important to have a radiographic examination, and then you can determine which teeth are resorbing and which teeth are over retained when it comes to deciduous teeth. So then you can plan your interceptive measures accordingly. So prolonged retention of deciduous teeth can occur due to several factors such as absence of underlying permanent teeth, endocrinal disturbances such as hypo or hypothyroidism or hypopituitarism, and also any ankylosed deciduous teeth that fail to resorb can be over retained, and the malposition of the erupting permanent tooth or teeth or the germs of them can also uh, cause the retention of these deciduous teeth, as they do not have an inherent pressure on the roots of deciduous teeth, and there won't be any resorption, and thereby these teeth are retained indefinitely. So prolonged retention of deciduous anteriors can cause lingual or palatal eruption of their permanent successors. If it's the buccal teeth, then there can be buccal or lingual eruption, or at times the successors can be even impacted within the jaws. Um, However, if there is a little deflection in the maxillary arch, it can cause the permanent teeth to erupt in a crossbite. And also, you have to remember that prolonged retention of a tooth is a direct cause for impaction of the subcutaneous tooth. So it becomes important for you to have a radiological examination, and several times, if an X-ray is taken at the right time, you might be able to identify and then correct these teeth from going into a malocclusion, and you can subject the patient to interceptor measures so that uh, you don't let these teeth erupt in abnormal positions and prevent future adverse effects from taking place. Also, the presence of deciduous roots, which are not exfoliated, can also cause the teeth to erupt either buccal or lingual to the presence of these uh, roots. So, it's important to assess um, in such cases, and also undertake measures such as extraction or removal of these root fragments so that you guide the tooth into its appropriate position. The next factor is the late eruption of permanent teeth. So by nature, there is a particular sequence for the eruption of individual teeth in each of the arches. You already know them. So what happens if these teeth don't uh, occupy its designated place in the sequence? So there is a likelihood of migration of other teeth into the available space. So as a result, what happens is tooth whose eruption has been delayed might get displaced or impacted. So it becomes extremely important to perform radiographic assessment and then decide if any interceptive measures are needed. The next factor is abnormal eruptive path. This is a secondary manifestation of a primary disturbance. Some causes are in cases of arch length deficiency. Deflection of the erupting tooth may be merely an adaptive response of the condition present. Also, there is presence of supernumerary teeth or retained displaced teeth or any root fragments, as we've discussed before. These might also result in abnormal eruptive pathway, and also presence of any traumatic displacement of tooth buds. Here, a deciduous tooth may be driven into the alveolar process, and it may displace the developing successor in an abnormal direction. And mechanical interference by orthodontic treatment can also cause a change in eruptive path. That is, if there is early class 2 therapy against the maxillary arch to move the to move the maxillary dentition posteriorly, can also cause the upper second molars to erupt into crossbite or can impact the developing third molar. So this is an iatrogenic uh, factor which can have an adverse effect on select few teeth and cause certain malocclusion states. However, these can be controlled as you know what is the resultant effect of these appliances, so you can identify them and then correct them at appropriate intervals. However, there will be some abnormal eruptive pathways due to idiopathic reasons. That is, a canine or premolar may erupt buccally or lingually, or maybe at times transposed with no apparent cause. And also, the first and second permanent molars are occasionally impacted. Third molars too are frequently impacted by an abnormal path of eruption, and also the presence of coronal cysts can cause abnormal eruptive paths. The ninth factor is ankylosis. So it's usually encountered during the age period of 6 to 12 years. So it might be a result of an injury, and as a result, there may be a bony bridge which forms between the lamina dura and cementum, and that's how a tooth gets ankylosed. So the most affected tooth is mandibular secundus molar. So also accidents or trauma, infections, congenital disorders like cranial dysostosis have a predisposition for ankylosis of teeth. And what you need to know clinically is the ankylosed teeth appears to be submerging, but is in actuality the other teeth are erupting and the ankylosed tooth is not. So that's what gives it an appearance of submerged appearance or submerging appearance. The affected tooth lacks any mobility even though the root resorption is far advanced. So that is again a feature you can identify on the radiograph as you can see here. And so that gives you an idea as to how these teeth can be either retained or extracted, and how do you go about treating such ankylosed teeth, and do you involve in the uh, such teeth in the treatment plan, or do you exclude them? When we discuss about anchorage of teeth, we will be going into more details on how we manage ankylosed teeth. The 10th factor is dental caries. Caries can lead to premature loss of deciduous or permanent teeth, and can result in migration of teeth, abdominal axial inclination, and also supraeruption of opposing teeth. So when there is proximal caries and the caries has been unrestored, or these teeth have been left unrestored, can cause the migration of adjacent teeth into the space, leading to a reduction in arch length. A substantial reduction in the arch length can be expected if several adjacent teeth are involved in um, uh, this phenomena and are left unrestored. So the last and the 11th local factor, which is improper dental restoration. So here, how can undercontoured and overcontoured proximal restorations affect teeth positions? That's what we're going to be learning about. So undercontoured proximal restorations can result in loss of arch length due to drifting of adjacent teeth, and over-contoured proximal restorations might bulge into the space and reduce the space for a subcutaneous tooth. And also, premature contacts on an over-contoured occlusal restoration can cause a functional shift of the mandible during jaw closure. Whereas, if you see under-contoured occlusal restorations, this can lead to supraeruption of the opposing teeth. So it becomes important to check occlusion whenever a restoration is uh, uh, given to a patient, because any improper restorations can have deleterious effects and can lead to altered position of teeth, and also can lead to problems with the TMJ or temporomandibular dysfunction, that is TMD, and associated symptoms. So with that, we will be um, reaching the last slide of today's lecture. So today we have had a brief discussion on the local factors causing malocclusion, and this was the second lecture in the series on the etiology of malocclusion. Previous lecture spoke on general factors, and today we've spoken about the local factors. So with that, we shall wind up today's lecture. Thank you so much for listening.